So I want to make a pitch for case management to you all in the community. Dr. Lamb referred to it briefly this morning, but I think it's really, really critical. You know now that there are medical and psychiatric aspects of this illness, and because of that, as many people as you can rustle up to be involved should be involved, and coordinating all of that information from all of those professionals is critical. Someone needs to be involved in collecting all that information, summarizing all that information, synthesizing all that information, and so you need a case manager. In our inpatient program, the psychiatrists fulfill that role with backup from social work. And when we've got a family-based therapy model on board, I would say that the therapist, in conjunction with the parent, is the case manager. And I think in the community, whoever you've got, I think if it's just a physician or if you have a team, someone should be assigned the case management role, perhaps child and youth mental health. So yes, there are medical and psychiatric aspects of the illness, multidisciplinary team. Once you've got all that information collected and synthesized, someone needs to decide what treatment or treatments need to be involved and make those necessary referrals. The other thing about eating disorders is they take a long time to go to their completion, and that journey is not linear. So there's relapses and better times, and because of that, patients are moving in and out of systems, in and out of hospital, in and out of school, in and out of various treatments. And I was just talking to someone about transitions and how stressful transitions are for these kids. So there needs to be planning for those periods, and someone needs to be doing that. So I wanted to illustrate the importance of this even more. So I've got a really lengthy example. So Jane, 14 years old, home from 2-week hospitalization for medical stabilization and NG feeds. And by the way, I just made this up out of my head. After 5 consecutive days of no food intake, only water, new diagnosis of anorexia, older diagnoses of major depressive disorder and generalized anxiety disorder, and Jane self-harms. When she's discharged, she's 80% of her healthy weight, and she's taking 40 milligrams of Prozac daily. Jane lives primarily with her mother and younger brother, Jack. Her parents are divorced, and they don't communicate well without arguing. They share custody. Fun. The children go to stay with her father every other weekend. Both parents want to try doing family-based therapy. Jane excels academically, but struggles socially since entering high school. She was bullied by her female peers in her class, and she's been attending school intermittently since she got sick with her illness. So this just scratches the surface of what you might learn about in a patient and family situation where there's an eating disorder. How the heck do you manage all that information? So this is a tool I wanted to offer you. It's one that we use in the hospital with a new admission. And I fill this document out. It represents a way to capture the main medical, genetic, heritable, psychological, family, and larger contextual factors of a given patient and family. It supports thinking about goal setting for care, including which therapies to introduce, which systems to involve, and what barriers there might be to recovery. It reflects the agnostic, or we don't care about the cause, stance that we take where eating disorders are concerned, as is reflected by the predisposing factors, which are factors that we think might raise the risk for developing an eating disorder. The precipitating factors are the factors that happen around the time that the eating disorder started, or what triggered it, you might say. And those factors, those perpetuating factors that might get in the way of recovery. It also reflects a strength-based perspective, which I think is hugely, hugely valuable. So, when you get I plugged in what little information we have about Jane, and then you can start to see how this document is useful. You can look at the perpetuating factors. She's low weight. She has these other mental health issues. She's experienced bullying. She struggles socially. She's coping, but she's coping in maladaptive ways. And she lives in 2 households, and her parents don't get along very well. And there's an unsafe school environment. So you get a sense of what some entry points for treatment might be. She's got to eat. We have to treat the mental health issues. We might need to do some trauma therapy. We might engage the school around social stuff, and we might engage them around safety, general safety school-wide. And we need family therapy, right? So that gives you an idea where you can start to be involved. So with that, I hope you maybe consider this tool to use to help you in your thinking.